Snoring is definitely an annoying problem. We all know that, and we tend to ignore it until, someone tells us that they can't take it anymore. A lot of times this is the complaint. My wife told me that I have to come and see you, or my husband. Because you sleep, you don't have a problem. Although the snoring is a lot of time beyond just the snoring. It has a lot to do with our health in general. And it's a reflection of serious problems sometimes. So what is snoring? Snoring is it's a simple mechanical, mechanism, I would say. It's the airflow through our airways. When we're awake, our airways are tight, nice and open. The muscle tone of the throat keep everything in let's say good order and shape. When we sleep, the muscle tone become more loose, and sometimes there's another factors to it. But when the kind of airways become, or the muscle become more loose, the air, when it flows through the throat, trigger this vibration. And actually, I found this on YouTube from a Dr. Chung. He is an ENT doctor who did a scope to a patient with the history of with snoring. He actually started with normal airways to snoring from different etiologies. And I thought this is very nice to show to the patients. Let's see if I can bring this here. Seems like it's not working. But it seems like it's not working. But I found this is, if you can let him know, he can help us, and we'll come back to this if we could. What I want to show you in this video is how the airways can be like really floppy kind of, and when we sleep, and how the snore happens, how the vibration through the airways. The problem, so start with habitual snoring is relatively common. So on epidemiological studies, 44% of males and only 28% in females has problem with snoring. Now, occasional snoring is high. I'm not able to calculate. So I'll let him try and see if it works. But what I was talking about is, again, habitual snoring is relatively common. 44% males, 24% females has habitual snoring, aside of other serious problem, which is the sleep apnea. But occasional snoring is very common. Almost everyone has, occasional snoring, tired for some reasons. But we don't worry about that. We don't actually, if you sleep by yourself and you're not having, no bed partner to complain, and you don't have serious obstructive sleep apnea, sometimes it's okay to some degrees. The problem is when we have snoring associated with sleep apnea. Now, when we're talking sleep apnea, we pass the I'm snoring, it's annoying to my bed partner, I'm okay with it because I'm asleep, to a serious medical problem that will affect the patient directly. It's just about you, about risk of stroke, heart attack, diabetes, hypertension. Now I'll show you some statistics based on research. No, we continue. Again, so sorry we could not play that video, but I highly encourage all you guys, if you can, you look at it online. It's very important. Why? Because you can see, you know, the airways. You can see what happened on, you know, not in like real lifetime kind of. So it's very informative. I think. So the main problem or the serious problem with snoring is, beside the troubles that cause to the bedside partner, is obstructive sleep apnea. Now, when we're talking, I'm going to talk a little bit about the bed partner trouble. Actually, if you sleep with someone who snores, you probably won't sleep. Your sleep is very shallow, so you suffer, you know, from the same problems: the lack of sleep, the poor quality sleep, which leads also one way or another to serious problems. So snoring is a big deal to the bed partners. And I was consulted on cases where people almost getting divorced because of snoring issues, where the bed partners refuse to have any, pay any attention. People don't have multiple bedrooms, and so it can be a serious problem, the snoring to the bed partner. But aside of that, for the patient, obstructive sleep apnea by itself, it's a serious health problem because of association with diabetes, hypertension, stroke, cardiac disease. Here I can show you that. So normal airways, we breathe mainly through our nose. The airways naturally narrow. You can see it, and but the air still managed to flow nicely without problems. Now, when the airways become a little narrow, what can cause that to happen? Some patients have smaller jaw. Some patients have bigger tongue. Some patients have more fat tissue in this area here that put more pressure on the airways. Start by again, snoring when the airways are narrower, and the turbulent flow through the upper airway starts from the uvula to the voice box. And then at some point, the patient snore and the airflow become at lower level, not at times enough to bring adequate oxygenation to the lungs. So you start seeing what we call it the hypopnea, which is not complete apnea, which is the stop of breathing or ceasing airflow like here, but partial. But even this partial collapse of the airways can be significant enough to cause problems with oxygenation. We see a lot of times the airways are not completely closed, so the bed partner or whoever monitoring the patient, they say, you don't stop breathing completely, but you have shallow breathing. We see you breathing very shallow, and this is a lot of times, and when we monitor the patient during sleep studies, we see the oxygen dropping significantly. And again, this is you see here, complete airway closed. This is what happens with sleep apnea. Your airway closed completely. You're asleep, you don't feel anything. I'll go over that in a little bit. First, what makes snoring worse? We know like anything that can cause the muscle to relax, especially in the upper areas, like alcohol, sedatives, pain medications. When the patient go to deeper sleep through the night, we tend to have more relaxation in the muscle. During the REM sleep, it's a stage of sleep where we are almost paralyzed in our extreme, because we don't want to have acting out dreams. So during REM sleep is when we have our dreams. So during the REM, normally we are paralyzed, so we don't act out our dreams. So the muscles become more relaxed, so we see more events, more snoring, more sleep apnea event during the REM sleep. But one of the problems with patients who has sleep apnea, that their sleep is so shallow, they don't even get to the REM sleep. So one of the nice things that we see when we put patients on treatment, which I will also go over in a little bit, that they start having dreams. The patient comes to you and say, I'm having dreams now, I can dream. I didn't have a dream for years. So this is one of because the patient with sleep apnea, they don't reach that stage of sleep. Again, there is patients with narrower airways because of being overweight, enlarged tonsils, and muscle diseases that can lead to weak muscles. The jaw size and position of the sleep position, what I meant here. So patient with smaller jaw, they have more crowded upper airways, so the tongue has smaller area to live in, and that will lead to what we call crowded upper airways, nasal congestion, and some patients, I want to just go over the nasal congestion a little bit, because nasal congestion, patients come to me and say, oh, I have runny nose, and this is, I think, my problem. To a certain extent, yes, when you have, the common cold or flu or something like that, you will have the nasal congestion that will lead you to snore for that time. But, as I showed you earlier, the nose is up here. The noise is coming from here. So the nasal congestion is of limited component of the snoring, usually. The snoring and the airway problem, and patient comes to me and say, I'm going to go have like septal deviation surgery or adenectomy or some surgery to clear my nose, and hopefully that will help. Actually, not usually, because again, the problem is with the nasal congestion is right here, but for sleep apnea, the problem is back here in the back of the throat, where the nasal surgery has nothing to do with it. So now, so let's start with patient who's snoring. When do we when we seek medical attention? When do we start work? Again, first thing, if you have bed partner that's having problems, because it leads to a lot of stress, even relationship problems, and so this is some good reason to ask for medical attention. If snoring is associated with other symptoms that can indicate sleep apnea or obstructive sleep apnea, this is a serious problem that needs medical attention. I'll go over the symptoms in a little bit. Now, for children, it's very important. Children who, any child who snores, that means that, there is good chance that they have sleep apnea. And in children, it's more corrected surgically, because children tend to have very large, naturally, tonsils here in the back of the throat. So surgical removal of tonsils make a huge difference. And the problem for children is that it causes serious attention deficits. And the children, they don't act like I'm sleepy during the day, but they do very poorly at school, and they have serious problems. So for children, it's very important, because you can cure the problem by only remove the tonsils, as opposed to older patient, which has nothing to do with their tonsils or not. So usually what you do is, physical examination. You see smaller. When the patient comes to the doctor, you see you can see being a little overweight. That's indication of the problem, because statistically, patients who are overweight are the patients who likely to have sleep apnea. We look at the patient's jaw, the tongue. You can tell the neck size is large. Again, input from the bed partner, family of a child can tell you about this sleep apnea, the snoring. Again, it can be just a simple snoring, habitual, but if it is related to sleep apnea, this is the serious problem. Now, to finish up with the snoring first, I will tell you, like, if it is a simple habitual snoring, just no indications of obstructive sleep apnea or serious sequences of sleep apnea, we ask the patients to avoid drinking alcohol, maybe like 4 or 5 hours before they go to bed. Sedatives can worsen sleep apnea, as I mentioned. Sleep deprivation can cause worsening sleep apnea. And overweight, this is one of the common risk factors for snoring. Treatment for only habitual snoring is weight loss, avoid alcohol late evening. Sleep position, patients tend to snore more when they sleep on their back. Sleeping on the side significantly usually help. There's different treatments, we call it positional therapy. I asked some patients to saw a tennis ball on their sleeping shirt, or there is actually devices or you can wear that will not be comfortable for you to sleep on your back. It just only allows you to sleep on the side. More advanced therapies like oral appliances purely for sleep apnea. It's a device that you can wear and it will push your jaw forward. When it does that, it creates more room for you to breathe and hopefully help with the sleep apnea. Surgical intervention. Unfortunately, for one thing I want to make sure that you know, unfortunately, for habitual snoring, oral appliance, which is very expensive because it's custom made about $4,000 or $5,000, is not approved by insurance. So it's a lot of money to spend on this device. Surgical intervention, same thing. It's not approved for habitual snoring, including laser. Even CPAP is a good treatment, which is a positive pressure. You just push air with the pressure, keep the airways open. It's not approved for snoring, but it's approved for snoring with sleep apnea. Now, this is the oral appliance I mentioned to you. It's a weight device that pushes, you see it pushes the tongue forward, pushes the jaw, and create more room here for the air to flow. This looks ugly, but this is not, we don't use this anymore. This is a nasal device that pushes air and push the jaw kind of forward. But it's too extreme. I've never used this before, but it looks like, and this is the positional therapy. See the tennis shirt or the bumper belt, which is allow you only to sleep on your side. And it does work actually even for sleep apnea a little bit. Does not yet for positional events. Some patients have only sleep apnea or snoring when they sleep on their back, and that might be helpful too. There's another device that create positive pressure. It's a valve that allows the air to go in, not out. So create positive pressure in the back of the throat, and that will keep the airways open. We don't use that. I never had any success with that. When I was in Houston, Taylor, we had a few cases that did not work, but it's just, I have to tell you what's out there, kind of. Now, I will move from the snoring to the sleep apnea, which is, I call the serious problem that associate with sleep apnea.
Before we go on to that,
Sure.
That mouthpiece, the $5,000 one,
The oral appliance, yeah.
do you use that much? I'm just wondering if it's gonna, do some permanent moving of your.
Not permanent, but so the oral appliance, in the literature, there is a lot of studies on oral appliances, but for sleep apnea, for snoring, it does work actually also nicely. But for a patient to be able to use oral appliances, they need to have their teeth. It can worsen in TNG. It's not very comfortable, but for some patients, CPAP is no way we can use it, and this is the other reasonable option. And it's I have patients who had great success, but it's not very comfortable, I would say. It's a problem that needs commitment, kind of. It's not easy to deal with. But I'm going to just show you that the serious problems that comes with it, and that's how I sell this to my patients, by telling them what can happen to them if they don't. When I tell and I'll go over it in a second. Did I answer your question?
Yes.
So sleep apnea is when this airflow goes significantly down to a point that leads to low oxygen. Now I want to simplify this, and this I explained it in my office briefly, is that we are overweight. Most of the patients do. Besides that, some patients have, again, anatomical problems, or including large tongue or smaller jaw. But generally speaking, patients has more fat in this area here. When they're awake, when we're awake, I will think about that way. Airway is nice and open. You sleep. We start the fat here along this normally narrow area. We start putting pressure. Start by snoring. Also, literally, and you probably have, some people have heard that, like you see that or you hear the airflow stop, and then it takes few seconds, and then start breathing it. So what happens through this few seconds? It's very important. So the airway closed. Now you're no airflow to the lungs. So the oxygen starts dropping, and it happens fast. It's like literally someone is closing your airways. Someone trying to suffocate you. You're asleep. You don't feel anything. Your oxygen. Now, when you're awake, if I ask you to hold your breath, you will not be able to hold it enough for your oxygen to drop when this falls off. Interestingly, when we do the sleep study, the airway closed, and you see the oxygen drop and drop and drop, and the patient won't feel anything. You see the oxygen go to the 80s, 70s, and normally if I ask you to hold your breath, there is no way you go below, like if your normal lungs below like 97, 96. No way. I mean, it's very hard for the body would usually, when we're awake, react very strongly to this suffocation feeling. But when we're asleep, the body takes so much lower oxygen. So oxygen of 100% start dropping, 95, 90, 80. At some point, so the brain, while you're awake, while you're asleep, get to a point that I'm suffocated now. Every cell in our body lacks the oxygen. At some point, the brain says, okay, I'm dying here. And this is how I say it, because this is how it is. Lack of oxygen is, suffocation. So the brain says, okay, I can't take this anymore. The brain gets something, we call it arousal. And we see this on the sleep studies, and I hope I have some that I can show you. The brain, without you guys waking up, but the brain get this arousal. And this arousal enough to send a signal to the air to the patient. And sometimes it does not go this big, like, or sometimes it's very shallow. And they stop breathing. And start happening. So it's usually on a lower scale most of the time. You don't hear it, but I'm just trying to make it clear, kind of. So, so when you think about it, when your oxygen is low, okay, the brain cells are suffering the lack of oxygen, the heart, the skin, the eyes, the muscle, every part of our bodies suffering the low oxygen, right? Because we are oxygen dependent. I mean, we cannot live without the oxygen. But this did not start most of the patients yesterday. They've been dealing with this for years and years. And our body is so good at adapting to the problem. So think about it that way. you're awake, you slept for, let's say, 8 hours. And in our country, we don't sleep 8 hours. Most people sleep 6 hours, unfortunately. But let's say you sleep for 8 hours. And you see on the sleep study, when I look at the raw data from the sleep study, you see the patients spend a lot of time, sometimes 50, 60, 70% of their time with low oxygen. So you sleep for 8 hours, but your brain suffered the lack of oxygen for 60, 70% of the time. Your body is suffering the low oxygen, the heart, the brain, everything, every cell in our body is suffering. So what our body's natural reaction, when I try to suffocate you, our body is storm this, what we call it, stress hormones or stress chemicals that lead you to have fast heartbeats, the cortisol levels goes up, the body tries to react to this very serious event, which is the suffocation. Now, when the cortisol or those stress hormones are released, this is when you have irritation to the heart muscles, and then you have those what we call arrhythmias. That a lot of times patients with sleep apnea die during sleep because they have this arrhythmia while they're asleep. As opposed to other patients who have heart problems, they die while awake. So the percentage of patients dying from arrhythmia while asleep are higher in patients with obstructive sleep apnea. The other part of the problem is when you release those stress hormones, the blood pressure can go up. The glucose, the patient has diabetes. We know that when we give someone prednisone or steroids, their glucose and sugar goes up, and this is what happened to during those events because you release those hormones, so the glucose goes up. It's a stress to the body needs to handle. So it's those few seconds are very stressful. Now, what I'm trying to tell my patients, I have patients who have 100 events an hour, meaning within every minute they have 1 or 2 events. So can you imagine how stressful their sleep is? So they wake up in the morning, are tired. A patient tells me, I slept for 8 hours, but I'm tired. So why are you tired? You're tired because your brain was suffering all night to keep you alive. So it's just instead of relaxing the body. In fact, you're better off awake sometimes because you don't go through this stress while you're asleep. But patients are sleepy all the time. Why am I sleepy? Because you're not sleeping at night. Your body is suffering. Your brain is tired. This is why patients are, and this is coming to the symptoms associated with the sleep apnea. Let me see if I have it. So patients, have the daytime sleepiness, lack of energy, lack of concentration, unrefreshed, and so on and so forth. So I'll go over epidemiology. I mean, this is very old study when in 1993, sleep apnea was not a big deal at all. In fact, we did not have back then a fellowship or training, official training for sleep. For sleep medicine. So, but back then they did epidemiology study, was published in a reputable medical journal, and the study estimated that 40 million Americans has sleep apnea, which is significant, very significant. And the statistics based on that study, that patients who have 5 events an hour, which is mild. I have patients with 100. I have patients, we call it severe if you have 30 events instead of 5. But with 5 events, about 20 to 30% of middle-aged males, 10 to 15 middle-aged females. Again, the sleep apnea gets worse when we get older. The chances of having problems are more when we get older. More than 50 events was 4% versus 2% males and females. Again, though this study, I think the numbers is much higher now. Although this is a huge number, we're talking 20 or 40 million. This is a huge number, but now it's much higher. Remember, we are aging more and we are gaining more weight, over the years. Now, what are the signs and symptoms of sleep apnea? Again, snoring. Patients have frequent, a history of snoring, restlessness, sleep, unrefreshed, wake up not refreshed, daytime sleepiness, sometimes witness apnea by bed partner, lack of energy and concentration. Patients usually are overweight, but does not mean that patients who are with normal weight cannot have the problem. Why? Because I mentioned the anatomy, believe it or not, our genes. Patients with family history of sleep apnea has higher chance of having sleep apnea. So actually recently I diagnosed a guy I met with, I was doing some workage, and this guy was telling me the symptoms, and I diagnosed him, I brought him to the sleep center, we did a study. And then his son is a doctor with me, and same thing, he's healthy, but I told him, check with your family, and his son has the problem too. And genes has a lot to do with this problem too. Again, patients with larger neck size, hypertension, patients with heart failure should be screened more frequently. Why? Because there is a study now to indicate that patients with heart failure with sleep apnea tend to die and have higher morbidity and mortality. They can get sick more, get to the hospital more, and die from their heart problems more frequently. So patients with heart failure, I pay more attention. And there's new data also to support patients with lung disease. I'm a pulmonologist also, and I do more screening for my patients with COPD, because study has shown that patients with sleep apnea and COPD tend to have higher what we call it morbidity and mortality, meaning getting sick, getting into the hospital, or dying from those illnesses. So I screen those patients more, and so what do we do in this setting? And also I'm going to add to this actually problem, atrial fibrillation. It's a problem with irregular heartbeat. That study it's getting very common, a very problem in when the risks of atrial fibrillation increase with age, and with our patients aging, increase the risk for this atrial fibrillation. Now, study has shown, and I want you to understand how significant sleep apnea. They brought patients with this irregular heartbeat, treat them with a procedure, we call it ablation, where you go and try to burn those sites trigger this atrial fibrillation. 70% of patients who had the ablation and have sleep apnea, they have recurrence of the atrial fibrillation after the procedure. So it's really significant. It's very significant, the recurrence. That means that this big procedure, the ablation, 70% of the patients will have the problem again there. So I highly recommend that any atrial fibrillation patients will undergo any intervention need to be screened. In fact, I talked to the electrophysiology cardiologists who treat these patients to screen these patients even if they don't have the typical phenotype of sleep apnea, because it's very serious. Now, what do we do when we have those symptoms? And just discuss with a primary care doctor and go over the symptoms again. I mentioned that. One thing I did not mention, but beside the previous mentioned symptoms, depression. Depression is very common. Actually, when I used to do my questionnaire for the patient, I have a depression questionnaire because depression is very common. Can you imagine most of your life not sleeping well? Yeah, that's very stressful on the body, and that leads to depression. Car accidents. Car accidents is a very serious problem. Patients tend to have those, what we call it, micro sleeps. They, sitting on the traffic light goes off or driving dozes off. You're sleeping during the day. Why not? You can have those micro events where you just doze off, driving or watching TV or read that, and those can lead to, can cost people their life, and we see that a lot actually. So, and again, attention deficit disorders, and the last thing I want to mention here is like sleep apnea is known to affect mortality. Patients with sleep apnea, significant sleep apnea, tend to die younger, a lot younger. Sometimes their study indicated 10 years younger, just from, compare patients with sleep apnea versus normal patients. You take away all the other cofactors, and they die on some studies 10 years younger, just when they have the sleep apnea. So this is how serious is the problem. And that now I mentioned to you earlier what happened with the sleep apnea, hyperglycemia, or diabetes. Your body is stressed out, release all those stress hormones, and you have high blood sugar, hard to at least some patients have diabetes, hard to control. You do and they have sleep apnea. Why? Because the body is releasing the stress hormones that despite taking the medication still have uncontrolled blood sugar. Cardiovascular disease and heart failure, I mentioned that there is increased mortality with obstructive sleep apnea, high risk of stroke, atrial fibrillation, high blood pressure. Those are all serious, life-threatening, heart and problems. Study has shown that 25% of patients with hypertension have sleep apnea. So if you screen 100 patients, 25, that's a big number, have sleep apnea. There's study, also epidemiological studies on patients with myocardial infarction. Patients, if you take, I'll just go over this, there is significant increase in mortality or death from coronary artery disease with patients who have sleep apnea. So if you bring patients with sleep apnea and without sleep, patients with sleep apnea tend to die more percentage-wise if you compare the two patients. Stroke also, if there's a study where they have 128 patients, some patients have stroke, full stroke, or TIA, or transients, or mini strokes. 62% of patients who have sleep apnea or 10 events, more than 10 events an hour, have a stroke versus only 12% with the control, patients without the stroke. So it's a significant number. Death, I mentioned that before. Mortality comparison between patients with or without sleep apnea, 4% versus 37% at 8 years follow-up. So patients with the sleep apnea on this study published at the Chest journal, if they have more than 20 events, 37% mortality in 8 years follow-up. This is a huge, okay? And 37%, this is like, horrible numbers. Now we have patients with cancer that we can cure, and have patients with cancer, horrible cancer, that survive with the therapy way more than 8 years. The problem is silent killer. Patients who were treated and followed up, they have zero mortality when they did this epidemiological study. So that's also impressive. And this studies, the cardiac sleep study, again, this is from the 1993. It's a very old study. 38,000 cardiovascular deaths related to sleep apnea based on that study. This is a huge, also 38,000. Again, social impact, car accidents were significant. On studies, they say seven times increase the risk of auto accidents. I think it's more than that, but I mentioned to you the symptoms before. So patient has the symptoms, discuss it with the doctor. What do? We recommend sleep study. Now, if the patient is healthy without any other medical problem, now we do actually studies at home, called home sleep study. You take the device with you, sleep with it, and ask the patient to bring it back in the morning. We analyze the data and see if they have sleep apnea. So we can, for healthy patients, now patients with any heart problems or breathing problems, we want them to have the study in the sleep center because we can monitor more events, more details of the heart beats and the brain activities. Patient with stroke also, we like to do the studies in the sleep center. Now, sleep study, we ask the patient to sleep in the sleep center, hopefully up to multiple, does not look very good here in this picture. But this, usually it's what, but usually we have multiple electrodes on the patient's brain. And I'm gonna move this, that's not look good. But we hook the patients on those electrodes and we monitor brain waves, oxygen, heartbeats, muscle tones. You saw those bells, just focus on those bells. Patient, and we see the abdominal movement or the chest movement, and we can kind of get really detailed idea about what's going on. Now this is an example of, like, you know, how we look at the overall data. This is, as I mentioned, this is the airflow through the nose because we want to make sure there is airflow or not. This is the chest movement, abdomen, oxygen flow. This is the brain waves. I'm going to go over this here because I want you to see what I mentioned to you applied in the data we get from the sleep center. So this is the airflow, right? Through the nose. Now the air is flowing here nicely, right? Brain waves is the same, you don't see difference, kind of. Patient has mild snoring here. Now, you see all of a sudden, it's flattened. There's no flow. Do you see that? Right? So here's what happens when it's interestingly, and I want you to understand, actually those are more board questions, but it's very interesting. So the oxygen starts to drop before even the air stops flowing. Do you see here? 77%, 81. So the air, actually, the oxygen dropped when we start having shallower. See here how it's shallow down, the breathing is shallow. So the oxygen dropped even before. Why does that happen? Because all what you need is to have lower kind of airflow to lead to a drop in the oxygen supply to the blood. So you have the low oxygen, and then you stop breathing, and see here, the brain, see here the waves were kind of the same, and all of a sudden start having those big moves, and start snoring, and the patient does this big, you know, snore, and start breathing again. And the oxygen goes up, you see here again. There's some delay between this two, but the oxygen start to go up. Now again, the shallow breathing, the oxygen start dropping, and the airflow here become almost flattened, and the patient have another arousal and snore here, start breathing. And this is kind of what happened. You see the oxygen is dropping before even you reach that flat line. You see the snore here, you see the brain arousal, and do you guys have any questions so far? And this is here an interesting sleep study that I tend to show those to my patients in the office when I have a chance. Why? Because this is what you need to remember when you deal with this CPAP machine. So again, here, this is the whole study, the entire study here. When you're awake, you see this here, go to sleep, sleep deeper, shallower, deeper, you go deeper. You have like few events when you wake up, and then you get to the REM sleep. Here, see this green thing here, we call it REM sleep. This is the stage when you dream. And again, then fluctuation, this is awake, sleep again. So, here's how the problems start. Oops. Okay, there you go. So, here's the respiratory module is when the patient had the event when they stop breathing. Here, the airways, like, you know, there's a channel that we don't have here, is the snoring. You see the patient snoring here, and then stop breathing, and you have this line here. Now, when you have the line here, first thing happen is the oxygen drop. When you see here, this is not very good one, but the oxygen starts dropping. When the oxygen sees snoring, respiratory event, oxygen drop, the brain wakes up. This is the event. Snoring, respiratory event when you stop breathing, and then I can't do that. The oxygen drops, and then the brain wakes up. And see that this patient, how bad? Almost continuous events. This is throughout the night. Look at the brain waves here. The brain was aroused all night long. And when you see sometimes not much event, it's probably because the patient moved from the sleeping supine on his back to the left side. See that? Have less events. Not all patients have this when they sleep in the side, but this patient in particular, and I put this here to show you that physicians have some to do with the sleep. But see how, look at the snoring, a lot of snoring, a lot of this, and the oxygen is low most of the time. See that? When they have the events, the oxygen is low. Here, not much event, the oxygen is good. Now, at this point here, we make a diagnosis that the patient has sleep apnea, and because it was very severe, we in the middle of the night, we brought the mask, which is the treatment. The mask is a, think about it that way. You had a patient who airways mechanically closed, right? Because we said, like, you know, the airways become narrow and closed. This is mechanical problem. How do we treat it? With mechanical force. Blowing air into the airways, keep this airways open. So it's a mechanical problem. We treat it with mechanical air force and keep the airways open. And see here, we started here the treatment. We brought, this is the CPAP. Now here we don't have anything. Now at this point, we started the patient on the CPAP. It's a mask that's hooked to a little machine that pushes air. What happened? In the beginning, the patient seems like did not like the machine because he was awake here or she was awake. You see that? And then the patient went back to sleep. In the beginning, see how dense it was here? How light is here. So the pressure was only 4, we increased it to 5. Less events, no snoring, and the patient went to sleep, but still have a lot of events. Better than here, but still have a lot of events. So what did we do? Increase the pressure more. Now we went to 6. At 6, no snoring, the events spread out, and the patient, look at that. This is the big events. You start having REM sleep. This is when the patient starts the brain, and we call it actually a rebound REM, when the patient starts dreaming, because he did not have this for years. The moment he has the chance, I see sometimes patients have tons of those. We call it rebound REM or REM sleep, because the patient's just like, yes, kind of, I got it. And you see that the oxygen, how nice. And then we went up because still the patient has some events here. We increased the pressure to 8, and it's becoming much nicer, very spread. Look, compare here to here. Look at the brain arousals, much less. Significant change. Can you imagine your night like this versus like this? This is a huge difference. The REM sleep, the rest, the good oxygenation, it's worth it. If you just think that this is how I sleep, and I show it to my patients when they have problems. This is the same thing that we show to the patient. I sometimes print it out to the patient, because a lot of patients think, there's no way I can use that mask. But this is something that I tell my patients, let's give it a chance. Let's wait. Let's wait. Let's wait. And so, do you have any question about this? All right. So
you count nightmares as dreams, or?
No, not really. I mean, sometimes I can't say that has anything to do with this. I think you have the dreams. Sometimes, like, you have vivid dreams, but I don't know if it has anything to do with that. With the dream. It's just like in the beginning, you have something called rebound REM, where you're just, the body is looking for, or the brain looking for more REM. Did not have it for a while. And you start seeing, like I said, usually, look what he had here. This is his REM here. Do you see that? This is, and when did he have it? When he was on his side. Here, he would never dream to have that here. But when he went to his side, he had like this tiny bit of a REM. But look here. tons of REM. Percentage-wise, to the night of sleep, it's significant.
Yeah, I have like dreams and that, you know, but they like carry on, like, I'll be dreaming someone like awake or something, and then you get up, maybe get a glass of water or something, come back, and I continue on the same dream and everything.
That's very good, but I don't have a good explanation for that. If you can, I mean, there's no good explanation for that. I can't have one because the mechanism of dream is not very well understood. But if you have the REM sleep, which is the very deep sleep, it's let's say you stop here, you woke up in the middle here. It's just the sleep. When you go back to sleep, it will start from the beginning. You'll have still stages. We don't go to REM sleep right away. We call it, there's certain illnesses that make, have you heard of narcolepsy before? Narcolepsy, when some patients go from, we call it sleep onset REM, which is very serious. Patients go right away to the REM sleep. It does not happen, it happens in teenagers usually. So I'm not sure if this is, or I don't have a good explanation for it. But I don't, unless it's causing trouble, it's actually not bad, unless the dream is bad. Yeah, I totally understand. But I don't have a good explanation. I don't think it has much to do with that, with the problem. Because usually, again, when you wake up, you start from stage 1. See, this is stage 1, stage 2, stage 3. So stage 1, 2, and 3, and then REM. This is like typical, like steps. Okay, 1, 2, 3. This is usually how it happens. It's very rarely to go to sleep onset REM in general.
So you're saying that you really don't dream unless you're in REM?
Yeah, dreams happen during the REM sleep. Yeah.
Not any other time?
No, not usually. There is mainly dreams happen during REM. There's some indication that it can happen in different stages, like rarely stage 3, but what we know is that dreams happen mainly during the REM sleep.
So the people that they stop breathing, he does that. They're over 30 years and he's done. So is that feeding into the mortality rate that his body's being damaged every night, every time he does that?
Well, again, this is a problem that's probably, you notice that for 3 years, a lot of times, it's been going on for a while. And the risks, right, it's just, yeah, it's a problem that like, it's like a tumor that's slowly kind of causing trouble every night. It's not like, that he's been dealing with this for years. It's nothing that, not necessarily like something's going to happen tonight or tomorrow, but it's a cumulative effect. I did not put those here because I want to make it simple, but what happened with also with the sleep apnea, there is, the layer of blood vessels, the inner layer of blood vessels in patients with sleep apnea become relatively dysfunctional. This is very sensitive, very dynamic part of the blood vessels, and this is why we see increased risk for like coronary artery disease and stroke and this. So it's a slow process, that happens every night frequently, and that's why we worry about it.
So when you said that his oxygen, the brain is not an oxygen is being cut off.
Mm-hmm. At some point it does.
So losing that little bit of oxygen every night or almost, is that doing a little bit of permanent damage to him every night, every time?
Not every time, but patients, when you sleep, you have low oxygen. It's stressful to your body. It will increase your risk for those things I mentioned, like stroke, heart attack, diabetes. Why? Because the body is trying to react to this suffocation. So if you survive the suffocation, let's say we have an incident where we are near suffocation, we survive that, we tend to do okay one time. But the problem is that this happening frequently at lower scale and lower level, and we are not noticing that. And that's the problem with it. But like just, you know, I cannot say immediately it's hurting him. I believe it's a cumulative effect over time. And this is why, you know, we worry. I don't worry about, I tell my 30 years old patient that you're at risk because young people tend to go and come back when they are 50 and 60 with a stroke or heart attack, and then the damage is already done. So yes, if you have the problem for 30 years, yes, you do have, I believe, problems from that. But you know that I cannot identify unless he comes to me with one of those serious problems. I cannot identify it, but I think if there's a problem, it has to stop today, and hopefully that damage will be stopped here. I don't know if I go retrospectively, although if we go back to this here, we see patients who were treated with CPAP have much lower mortality compared to patients who just followed. And those patients had 20 or more events an hour, followed for 8 years. 37% of those patients died in 8 years. Patients who were treated, 0. I don't know the stages of that, but I can tell you based on this, you can stop the damage by treating the sleep apnea. And this is why we like to increase the measure.
Okay, when he does that, he stops.
Mm-hmm.
The brain will always kind of kick in though?
Great question. So yes, usually yes it does, but here's the problem. Have a glass of wine before you go to bed, and the brain does not necessarily have the same threshold to wake up. So some patients you go you're having a headache and you took a Norco, right? So as simple as Norco in patients who has severe sleep apnea, again, normally you get to the point that the brain get aroused, right? When the brain gets aroused, the brain with the Norco have, you know, again, a higher threshold to become aroused. So your oxygen drop a lot more, and problems can be a lot worse before the brain recognizes it. And that's the scary, dangerous part. This is why we talk about sedatives, alcohol, because this is how it can cause damage. And this is because we all tend to have, a lot of you have like a glass of wine with dinner, but for someone with sleep apnea, it will, you know, change the arousal threshold and make the patient go through lower oxygen and more stress to the body. Did I answer your question?
Oh, yeah, yeah.
Okay. So we'll. So again, I'll go over that. The management of sleep apnea is we do what we call a comprehensive approach. You have to have the sleep study, understand the problem. Yes, not everyone feels like this is a great thing. The CPAP machine is not very comfortable to some people, but I can tell you my personal experience with my patient. I see a lot of patients with sleep apnea. It's a very common problem. I have patients who tell me, I always bring this example to show that it makes your life better. I have a patient who is a hunter. He goes hunt. So he bought a battery to take the CPAP machine on his hunting trips. This is how attached to it. I have patients who will never travel without their CPAP. If anything, I have tons of patients, not one or tons. Most of my patients who are using the CPAP, they tell you, I cannot sleep without it. It's just, so it's not sometimes like when you think about putting the mask and pressure, and that looks too extreme, but actually when you wake up refreshed, that's really nice. When you're not sleeping during the day, it's very nice. And when you sleep without it one night and you're tired, not refreshed after you saw the difference, it's worth it. It's definitely worth it. And I have patients who, like I said, I have patient tells me I love this vision more than my husband. Sleep make me comfortable. I wake up and really, I mean, I'm just telling you stories because it's really into some patients. Now we have to come up to this therapy with open heart, I say. Why? Because you need to understand it's not comfortable, but it's a serious problem. You know, as I mentioned to talk to you, it's not like, you know, yeah, a little snoring that I can handle. We're talking serious problem. Death, morbidity, mortality. So it's not like, yeah, but to me, it's better than a pill that have bad side effects. At least I know that rarely you have any side effects from this device. Medication that we use for everything has side effects, right? I mean, right? I mean, it's just, it does not have much side effects there, right? So I would do this therapy. People ask me, is there a pill? I said, no. I would not trade this with a pill because pills usually tend to have side effects. Although we don't see this usually right away, but everything has side effects. Go ahead.
But is there a person, some people who cannot use
Yeah.
the mask?
Yes, there is good percentage. Depend on one of the things actually research and I noticed personally is when the patients come to you and you want to have the problem treated, they'll find a way. If the patient is pressured by spouse or to do it, they don't feel like, they feel like they were forced to do that, and naturally they don't. So I tell my patients, I want you to understand, take your time, because insurances are not easy to handle with this. So for instance, I prescribe the machine, you go and you don't use it, they will take it away from you. You know, there's compliance issues that they want to make sure. It's expensive therapy. It's lifelong. There is always maintenance, masks, machine, sleep studies. So it's an expensive problem, relatively speaking. But insurance recognized how important it is that they're willing to fully pay for it because it's worth it. But if you don't use it, they tend to take the machine before they, you know, if you don't use the machine when I give it to the patient first few months, they take it away from the patient.
How do they know if you're not using it?
The machine actually has nice download. The machine can tell everything, can tell how many events you have. Those machines are very sophisticated. Actually, through Wi-Fi, the machine now can tell the vendor if you used it or not.
Is it noisy?
No. The machine itself, you have noise usually.
Not less noisy than the snow.
Well, yeah, but it does not, I agree. But it's not noisy. The machines now are this small.
They're small or?
Very
quiet, or
small, very
they're
quiet.
or-
Let me see if I have anything. This is like, you know, this is actually one of the older machines, but there is now the disease is now are really, you know, advanced, and there is a lot of, you know, inventions, and now you see this mask, there is patients who like big masks, patient who likes small masks that go inside the nose, patient who likes, this guy has small nasal mask, so everyone has different preference.
But who determines? Yeah.
So when the patient has the study, usually I ask the staff to try whichever looks more comfortable to the patient, and then when we use it, if the patient likes the mask, we order it, and then some patients come to my office and say, I don't like this mask, it's too big, too small, leaking. Then we try and try and try and try, and this is something that you will use more than anything else, more than your car, more than your phone, more than anything. It's just sitting on your for 7 hours. So it must be the best. Must be, and everyone has personal preference. Go ahead.
Yeah, I had a sleep apnea now, and I had the test done here, and I had it done once before. And I was one of them that could not get used to the mask, you know, I'd seem like I had more problems when I get up. You know, my mouth would be dry, and my nose, running nose and everything. Sometimes it would even be off of me, you know, I couldn't get a good fit, so. I basically quit on my own, as she was saying, I stopped snoring and everything, and you know, and the grandchildren were happy that it wasn't as they could come over and sleep with me, you know. So then I had a sleep test done here, I think about a year and a half or something, and going through the same problem. When I go to this place on Essington, and they never really did much for me. They just like give me the mask and explain nothing to me. They didn't tell me how serious anything was, you know. And I do have heart problems with Dr. Sumita there. But, I had one mask and it didn't work. I tried and tried and tried, really tried, you know. It would not work, and then so they said I was eligible for another one, and I got one similar to this, except it's a newer one that comes out the back. And, it's just like the same thing, it's just like, I guess maybe because it's coming out the back, the thing is falling off and everything, so would my test show something, or?
No, so in this setting, as long as we know based on the study that you have a problem and you have a disease, it's diagnosed based on the sleep study, the problem is now the mask.
So would a full mask be better?
So try everything until we find the perfect one.
But see, they only like,
The problem with that, and I don't want to talk about the problem with that a lot of times is insurance issues that need some more work. So for instance, the vendors now usually, when I order a mask, I said mask to fit, meaning they need to come to you, show you this, that, until you say, oh, that's feels comfortable. And then, if you don't like it, within 1 month, you can swap it with something else.
Right.
So there is ways around it. And I tell my patient, I encourage them actually to try multiple masks. There is ways. If the insurance doesn't cover, there's online, cheap, it's on eBay or over. I'm not suggesting, but there is ways. I mean, this is something that, as I mentioned, needs to be treated.
So, can you go more than one time? Like, I went back to I think it was Airflow or something like that. And they said, well, we can only take it like one time. You gotta wait 6 more months and then you can get another mask or something. And I just get no results out from that.
Well, again, I don't know the perfect setting to what was happening, but yes, usually try different masks within.
Give it to me.
Well, if they said they need 6 months, then I have two suggestions. One of them is try to buy something cheap online, like find the one. But that's sad because I usually want the vendor to try and find something that is more appealing and comfortable to you. Since you try many, it does not make sense for me saying try this and go. You need with someone who is to sit with you. The problem is with insurance payment and issues like some of them are good, some of them not good. I personally don't have a preference, but I tell my patients, if you have a problem, let me know. So what happened in this setting, I'm not suggesting that, I'm sure, but you need to talk to your doctor about it, because I send so many patients to those vendors, and when my patient complained to me that they did not take good care of me, I will have my staff call them, say, you did not take it. They explain to me what happened, or I say, I'm not going to use you anymore. They will lose a lot. So those are businesses. So either take care of the problem, and sometimes they come and reach out to the patient again and say, okay, try this mask, just, not because they, but just they don't want to lose that business that comes with this, with the sleep center. So they take care of the patient because my volume or our volume here. But this is what I suggest, that your doctor talk to them, say, figure it out. Find me, this guy has a heart problem or something.
Well, you just say that all my symptoms are sleep apnea because I took a lot of different tests and this and that.
Then you must find, we need to find, is it the mask? Sometimes we have patients with the claustrophobia, they just cannot stand the mask. And there's ways around, there is desensitization of this. Just have the patient, or put the mask during the day to get used to it. Watching TV without the hose, just put the mask on your nose and still watch TV. So you just become part of your normal, it's not new thing to you. Because yes, it's some patients with claustrophobia, they don't like this. But also on the other hand, there is a smaller, much smaller mask we call it nasal pillows, sits inside the nose, much less claustrophobic. Yeah, there is ways, what I'm trying to say, try different masks, try to buy them on your own if the insurance does not cover. There is ways, but the best thing is to have someone professional try to fit you to.
Where would we find someone?
That's a good question, but unfortunately insurance covers where to go. You know,
Yeah.
I tell my patient I would never own a sleep center. I would never own like one of those companies because those are businesses. They want to make money. It's different. I'm not saying, you know, so you need to find a middle ground. Someone with, you know, who can, like I said, you have to have your doctor talk to them about it.
Thank you.
Sure. All right. Those are all treatments. Look at this before. We used to have this device. And it's still there, where you can actually bring the tongue, you suction the tongue out of the airway. So those are tough therapies, you know. We can't complain. Again, usually we want the patient to lose weight, avoid alcohol and sedatives, and nice sleep hygiene, fix hours of sleep and wake up, and you know, good treatment for diabetes. Stop smoking. Smoking associated with congestion in the airways, worsening snoring, worsening sleep apnea. There's new therapies. You know, this is something that's evolving every day. There's a lot of potential therapies, but for now, I think this is the best therapy, the CPAP. All right. Any question? Anyone has any question? Anything I can